Charlie, can you hear me?
Still can't hear you. Can you hear me?
I can hear you, Mitch.
Yeah. Charlie,
I can hear
I
Mitch.
can hear Mitch
Okay.
and you.
Yeah, I hear Charlie and I hear everybody else.
Hmm. Oh, so others can hear you, although I cannot. Aha, got it. I can hear you now. Hang on one second.
All right, you got me now? I just had a very nice tour of the medical center.
Hi.
Hi,
Sorry
Charlie.
about that. Now I can hear you. We're all set. We're only 16 minutes late. Apologies to you, especially, and to everyone for joining us in such challenging room circumstances. We're glad that you all can still join us, and we still have 31 people who are on here, which is just fabulous for our department seminar. So I'm just, without further ado, I'm just going to introduce you, and then we're going to move into it because we really do want to hear what you have. It's so interesting, the work you've done. So Mitch Elkind, who I've known for a while, since even before, worked a tiny bit before even coming to Columbia with you, is a tenured professor of neurology and epidemiology at Columbia, and is chief of the Neuroclinical Outcomes Research and Population Science Core in the Department of Neurology. His degree is from Harvard Medical School, and also worked in neurology at Mass General, and completed a fellowship in vascular neurology and neuroepi here at Columbia under Dr. Ralph Sacco. And we're also very proud that Dr. Elkind holds a master's degree in epidemiology from the department here. His work focuses on stroke prevention, inflammation, and infectious markers for stroke, as well as immunotherapy for acute stroke, as well, and vascular causes of cognitive aging. He's the PI of multiple awards from NIH, including from NINDS, which I think that he will tell you about today. He has served as the Stroke Journal's International Stroke Early Career Training Section editor, and runs multiple NIH-funded research programs for residents and fellows. He has had 3 terms on the National Board of Directors for the AHA, and 2 terms as chair of the ASA Advisory Committee and co-chair of several writing committees and so forth. He is also, so I have 2 really important things then to add on as to conclude, as Dr. Elkind was the president of the American Heart Association, which from 2021 from 2020 to 2021, which we're all very proud of, and that is a very big deal. He lives in New York City with his wife and 2 sons and a pet tortoise whose name is Lightning. And it's also interesting to, just little factoid, which I only learned, that your wife is Rachel Vale, who is the Just in Case children's book author, right?
Yes, she is. How do you know Just in Case?
Well, because my kids all have and read it. So It's my pleasure to introduce you and all your celebrity, but also Just in Case to other people. Okay, without further ado, please.
Thank you. Thanks, Charlie. That's pretty funny, actually. I'll have to tell her. Yeah, so today I'm actually giving this talk as the husband of Rachel Vale, basically. That's very sweet. Thanks. Yeah, she has like 40 books for all ages of children. So, you know, a little plug for Rachel. If you guys want to learn about our family, you can go out and buy her books too. So thanks. Thanks very much for having me to give this session today. I feel bad I haven't really had the opportunity to hang out in Epi as much the last couple of years. Of course, none of us have because of the pandemic, but it's, you know, I've been a little bit distracted by virtue of being the, you know, president of the Heart Association. And so I've had a little bit less time in Mailman and in the Rosenfeld building. And I just, you know, went by today for the first time in a long time to Hess Commons and got a snack there. So that was nice. Anyway, great to be here. We'll just jump right into it. I'm going to share my screen. And I'm going to do this. Okay, so I think you can see the slide. So what I thought I would do today is talk about the Northern Manhattan study and talk a little bit about EPI and then how some of the work we've done has led to other studies in in clinical neurology as well. So here are my disclosures, and there are a couple of things here, BMS, Pfizer, and Roche, that support a trial that we're doing called Arcadia, which I'll talk about at the end. That comes out of some of the work we've done, and chapters for up to date as well. So what I thought I'd do is talk a little bit about history, touch about my own, and then about NOMAS. We'll talk about some of the race ethnic differences in stroke that have been seen in our population here, and then talk about some novel risk factors for stroke that I've been interested in, specifically inflammation, infection, talk a little bit about post-stroke trajectories of function and cognition, and then atrial cardiopathy towards the end. So by way of history then, I don't know how many folks here are familiar with Hewlings-Jackson, but he's one of the famous British neurologists who worked in the late 19th century at Queen Square in London, which is a famous hospital that's devoted to neurological disease. And one of the things that Hewlings-Jackson is famous for is something called the Jacksonian March, which basically describes how a seizure can begin in, say, the foot, and then spread from the foot up the leg to the hip and the thigh, and from there out to the shoulder, and then out to the hand, and ultimately to the face with face twitching, for example, and then a full-blown generalized seizure. And that pattern of seizure is famous because it tells us exactly how the representation of the different parts of the body, in this case in the motor strip, are represented in the brain. And this homunculus also illustrates the way in which certain parts of the body are even more heavily represented in the brain than others, right? So your hand, your face get as much representation as your torso, essentially. And so I show this because it's a great illustration of how a very astute observer could find a pattern in clinical phenomenology, the pattern of a seizure, and use it to be able to describe where different functions localize in the brain. So it's a question of pattern recognition. And I first learned about Hewlings-Jackson when I spent a year in England after college studying history and philosophy of science. And from there, I went on to do my medical school and then my residency, where I had the good fortune to be at Massachusetts General Hospital, with one of the people who many neurologists consider to be a father of vascular neurology, or the field of stroke. And that's a guy named C. Miller Fisher, who passed away a few years ago, well into his 90s, but throughout his life described many of the classic neurological syndromes, especially stroke-related syndromes, that many of us take for granted now. And he similarly was able to use that same approach of recognizing patterns in patients to figure out where the problem had to be in the brain, and then what the pathology would be that would cause it. And I won't go through these in detail, but just to emphasize his ability to recognize patterns. And after I did my residency, I then came to Columbia, where I did the master's in epidemiology that Charlie mentioned, and worked with Ralph Sacco here at Columbia. And in this case, I had the opportunity to learn about not patterns in an individual, which is what C. Miller Fisher and Hewlings-Jackson and zillions of other neurologists have done, but also to be able to look at patterns in a population and use that to try to figure out what the causes of disease might be. And so rather than the individual patients or even a laboratory, this essentially is the laboratory that I was trained in and continue to work in now, which is, of course, our little chunk of northern Manhattan. This is an old picture. This is what it looked like back in 93 or so when the study started. You can see the George Washington Bridge coming off here, and the East River and Bronx River and so forth. So we've been around for a little bit over 25 years now. I think I was actually supposed to give this talk like 2 years ago, just before the pandemic hit. So I figured I'd use the same title. So now it's 25 years plus 2 years plus about 15 to 20 minutes finding my way back to my office to give the talk. So let me tell you a little bit about the Northern Manhattan study. And actually, this started out as the Northern Manhattan stroke study. And as I said, it was founded by Ralph Sacco back in 1993. And the study is actually a series of kind of nested studies, if you will. And I think it's really illustrative to think about how the Northern Manhattan study developed over time. And it's a great thing for trainees to see because it's a really good example of how to build a study. So we started out with, or Ralph started out with an incidence study, which essentially was counting the number of strokes that occurred in our population, which, as you all know, is just over 50% Hispanic or Latino, and particularly from the Caribbean and primarily from the Dominican Republic. And one of the goals of that study was to figure out what the differences were in incidence of stroke among the three different race ethnic groups living here, and also to look at outcomes after stroke. So it was a stroke case follow-up study. And then for the next iteration or cycle of the grant, what Ralph did was to shift from just doing case follow-up and to enroll a population of people from the community who were selected at random using random digit dialing. They had no prior history of stroke. And this allowed us to do case control analyses comparing the stroke-free population from the community to those people in the community who'd experienced a stroke. So they all lived within the 5 zip codes surrounding the hospital. So it was a population-based study. It wasn't everybody in the hospital who had a stroke, but just those who were in our catchment area. And that was fine. We were able to do case control studies. We were also able to do some cross-sectional analyses, looking at various measures, for example, of carotid plaque and echocardiography and things of that sort within the control population itself, so we could look at subclinical disease. But as you all know, being epidemiologists, there are a number of limitations to cross-sectional studies. People, when they are interviewed for a cross-sectional study as a control, they may give different answers than somebody who's just had a stroke and perhaps is probing their memory more deeply for potential risk factors and so forth. You know, for example, ask people about their drinking history. It may be very different if it's somebody from the community you're bringing in versus somebody who just had a stroke, and they may remember things that they wouldn't otherwise remember. And so the next cycle of the grant, what we did was basically to stop enrolling the ischemic stroke patients at all and to focus on this group of people selected from the community at random and essentially build up into a prospective cohort study, which is what we continue to do now. So it became like the Framingham study or any number of other prospective cohort studies that we could follow over time. And of course, using stored blood specimens or other measures we had taken at baseline, we were then able to do nested case control studies as well. So why do I show this to you? Well, I show it to you because to me, it's a perfect example of how somebody like Ralph, who was a junior faculty member at the time he started the study, was able to essentially bootstrap from following people in the hospital with stroke to a prospective cohort study akin to something like the Framingham study, right? So if Ralph had gone to the NIH back in 1993 and said, you know, I want to follow several thousand people for 30 years to see if we can figure out what causes strokes, they would have laughed at him. I never would have gotten the funding. But he started with a very simple, focused study, and then went to the case control and then prospective cohort. So it's a great example of how one can build something gradually over time, and you shouldn't be overwhelmed by the thought that, you know, how am I ever going to do something as big as that person, because they didn't start that way either. And it's funny because I talked to Ralph about this, and, you know, I made the slide, I showed it to him, and say, you know, that was really brilliant how you did that. And of course, he says, you know, I had no idea that was in the future. That's not what I planned at the start. This kind of, you know, again, it just built as opportunities presented themselves. So, and as we've gone on, we've had the opportunity to collaborate with a lot of people, including people in the Epi department here. Ralph has since moved to Miami. He's the chair of neurology there. We continue to be multi-PIs on NOMAS. And we have people from kidney disease here and other areas as well collaborating, cardiology certainly, and other areas collaborating too. And a lot of people who come through our T32 neuroepidemiology training program have used the data from NOMAS as well, and that also continues to the present time. And we've had many early career collaborators who've gone on to get K awards or other independent funding, and so it's been a great building block for many people, including myself. So we started enrolling, so I'll focus mostly on the prospective cohort in this talk. A couple of other little things I'll bring up, but as I said, we started enrolling people back in 1993, and they had a baseline assessment that included a medical history, neurologic exam. They had blood samples taken. Some of them in subgroups had echoes done and ultrasounds of the carotid artery and so forth. And they were followed up annually by telephone for outcomes like stroke, MI, and death. And as I say, they continue to be followed now. We have about 3,300 people that we've been following. Their mean age is 69 years old at the time of enrollment. So it's an elderly cohort. 60% or so were women. And as I said, just over half were Hispanic and about a quarter or so Black, non-Hispanic Black, and non-Hispanic white in the cohort as well. And this is a cohort with a lot of cardiovascular risk factors. First of all, you can see a lot of people have not completed high school education. There's a lot of people who get Medicaid as their form of insurance. So it's a relatively less advantaged or resourced population. And there's a heavy burden of smoking, diabetes, almost a third of the cohort, cardiac disease, and other risk factors as well. So it's a high risk population. And one of the first things that Ralph was able to do early on is to look at the risk, the incidence really of stroke in the white, Black, and Hispanic populations in our cohort. And among both men and women, he found that the Black population had over twofold increased risk compared to whites, and the Hispanic population intermediate. And this was, you can see, published over 20 years ago now. In terms of the types of stroke that occur, we have different subtypes of ischemic stroke, so atherosclerotic, lacunar, cardioembolic, and unexplained or cryptogenic. And you can see that all subtypes of stroke were overrepresented in the Black and Hispanic populations. Ralph also was able to look at specific risk factors for stroke, and interestingly, we found that certain cardiac risk factors were more important. This is showing the etiologic fractions for the proportion of stroke due to a given risk factor in our different populations. You can see among the whites, atrial fibrillation, which is a cardiac arrhythmia that we'll return to later, and coronary disease were more common as risk factors for the white population, much less common in the Black and Hispanic population, whereas among Blacks and Hispanics, hypertension and diabetes were particularly important, unlike in the whites. And so, although these are important risk factors for all people, the population level burden of the risk factors differed by specific population group. And we just recently, in the last year or so, published a kind of an updated incidence paper. And here you can see, and this is not looking at the population as a whole. This is actually looking at just following the people in our cohort as they've aged. And you can see again that the Black population, the Black participants have an increased risk of stroke compared to the white population shown in blue here, and Hispanics in some ages even outnumbering, particularly in the oldest group, the other two populations in terms of their incidence for stroke. And this is showing adjusted analyses, and it's broken out by age and sex as well, but the top just shows among all participants, unadjusted or adjusted for just age and sex, then for other demographics like education and insurance, and then for cardiovascular risk factors. And what you can see is that the Black population is at increased risk for stroke at all different ages compared to the whites. Hispanics Not so clear in those under age 70. In fact, there may be some Hispanic paradox or reduced risk of stroke in the younger group, although not statistically significant until you get into women over the age of 70. But importantly, all of the increased risk seen in the Black and, to the extent that it's there, the Hispanics, is essentially abrogated once we adjust for other risk factors. So there's not some, kind of underlying genetic or other reason why Blacks or Hispanics are having an increased risk. It's really the risk factors that occur, and presumably that in part is due to social determinants of disease. And we have some measures of that. We use insurance and education and so forth to account for that. And of course, there's probably residual confounding as well. So we're not getting all of the relevant risk factors here. But that tells us that we need to do a better job in treating those risk factors, I believe. All right, well, let me switch from talking about the race ethnic differences to some of the things that I've focused on since I joined the study. I got here in '96, so it really is 25 years for me. And I've been interested in things like inflammation, infection, and some other things. So let me just show you, first of all, this is the what's called the response to injury hypothesis of how atherosclerosis develops over time. And what this illustrates is that atherosclerosis can really be thought of as a chronic inflammatory condition. So in the old days, we used to think of atherosclerosis as being due to the gradual accumulation of lipids in the vessel wall, kind of a bland process. You're just shooting fat into your vessels, and they gradually thicken and ultimately occlude, and you have an event. But that doesn't seem to be the case. We've learned that any of these things listed at the top, particularly oxidized LDL or low density lipoprotein, can lead to endothelial injury or dysfunction that then sets in motion an immunological cascade. Leukocytes adhere to the vessel wall, they go beneath the surface, and they take up residence there. They release cytokines and growth factors. They recruit macrophages, foam cells form, the smooth muscle cells proliferate, and you end up with a fibrous plaque. And ultimately, you can then get rupture of that plaque that leads to a clinical event or a clot forming. And although oxidized LDL is kind of one of the major things that's been studied, you can see many other potential reasons for this up at the top here too, including toxins from cigarette smoke, mechanical forces like in hypertension, and so forth. And here, I would ask you if anybody knows what this picture is or who made it, but if we were in a room together, but I think I'll just tell you, this is an absolutely gorgeous drawing of a Purkinje cell, which is a type of neuron in the cerebellum. And the artist in this case is somebody named Santiago Ramon y Cajal, who, as you can see, worked at the end of the 19th century. And he actually wanted to be an artist, grew up in Spain. His father, who was kind of a tyrant, I guess, insisted he go to medical school instead, so he did. But he obviously used his artistic talents to great effect and made a career out of studying the nervous system under the microscope, and was able to make these absolutely incredible drawings, over 100 years ago, of neurons of all types. And he's both an artist and a scientist, really, and one of the founders of modern neuroscience. And in fact, you can see, here I just illustrate working at the same time was Gustav Klimt in Vienna. And there are interesting parallels in some ways between the kinds of work that Ramon y Cajal was doing and Klimt, just the patterns being very similar. And I show this because although he was studying the nervous system, Ramon y Cajal also made this absolutely terrific drawing of a blood vessel with a white blood cell adhering to it, and then what we call diapedicing, or migrating through the wall of the blood vessel into the subvascular tissue space. And this is a perfect illustration of this phenomenon of how something like atherosclerosis, for example, could occur. And remember, this was done over 100 years ago. So this is not a new discovery or phenomenon, really, that inflammation may contribute to atherosclerosis. In the Northern Manhattan study, one of the routine things we had measured on all our participants when they first came to us was a leukocyte count, which is a white blood cell count. And so we were able to look at the association of white blood cell count in these stroke-free people and its effect on the risk of stroke over time. And you can see that those in the top quartile of white blood cells were at increased risk of going on to have a stroke. This is Kaplan-Meier curve, it's unadjusted, but when we adjusted for other risk factors, the effect held, and there's a 75% increase in risk for those in the top quartile. Of course, there are many other inflammatory markers that people can look at and have looked at. One of the most well-known being C-reactive protein, and another interesting one being lipoprotein-associated phospholipase A2, which I'll tell you about in a moment. C-reactive protein is what we call an acute phase reactant. It's produced by the liver as well as endothelial cells, and it's essentially like a final common pathway of cytokine activation. So a number of different stimuli, they could be external, like infection, it could be internal, like immune or autoimmune diseases, lead to elevations in C-reactive protein. And in several studies, elevations in C-reactive protein in seemingly healthy people are associated with subsequent risk of cardiovascular events, including stroke. I'm not going to get into that in detail, but this has led to studies, clinical trials actually, using C-reactive protein as a target of therapy. And one of the largest of these and first ones of these really was a study called Jupiter, which took people who did not, they had to have no elevation in lipid levels, right, which are a well-known risk factor for cardiovascular disease. But if they had a very mild elevation in C-reactive protein, 2 or higher, then they were randomized to the statin agent, right, the lipid-lowering agent, rosuvastatin, and followed over several years. And the study showed that rosuvastatin decreased their risk of stroke, and particularly ischemic stroke, over time. And again, these were people without elevated lipids. All they had was a mild elevation in C-reactive protein. But of course, statins are good for almost everybody. They're going to reduce everyone's risk. The question is, what is your baseline risk? So this study didn't really prove that the benefit was specific to the inflammation. It just showed that in this population, like in others, statins could lower risk. The next study that was so interesting in this regard used an antibody that was directed, monoclonal antibody directed specifically at the IL-1 is an IL-1 inhibitor, directed at interleukin-1, which is a cytokine. And this study, using this monoclonal antibody, canakinumab, took people who similarly had no elevations in LDL, but they had elevations in C-reactive protein, and they were treated with this drug. And you can see that over time, there were no changes in their LDL or other lipid levels, but there was a dramatic decrease in their C-reactive protein levels. So this drug was focused on C-reactive protein and not the other cholesterol moieties. And what this study showed also was that there was a reduction in the risk of cardiovascular events, including stroke. But this study was not really, it looked at people who had a history of cardiac events initially. It wasn't really a primary prevention study. And so there weren't enough strokes to see the effect on stroke alone. And a single study, this is not really translated into clinical practice. It's an expensive medication, but people have since gone on to test other drugs like colchicine, a very common anti-inflammatory agent used for gout, for example, and found benefits there as well. So the idea that focusing on inflammation as a target of therapy has to some extent been borne out, although there's a lot more work to be done. And the issue with C-reactive protein is that it can serve essentially as an epiphenomenon for so many other risk factors, right? Unhealthy things like high blood pressure and obesity, increased CRP, beneficial things like physical activity, maybe even modest alcohol consumption, lower CRP. And so it's hard to point to it as entirely independent, although that remains a controversial topic. Lipoprotein-associated phospholipase A2, or LPPLA2, is another marker which to some extent is similar to CRP, but this enzyme oxidizes LDL and it co-localizes with LDL in the bloodstream. And when it oxidizes the LDL, it generates pro-inflammatory products and is associated with atherosclerosis in preclinical studies. And in epidemiologic studies, it's been shown to be a predictor of first ischemic stroke. And measurement of this was actually approved by the FDA as a measure of risk of first ischemic stroke. But the patients that I take care of and neurologists take care of are people who've already had a stroke. And so the question arose, what is the benefit of measuring C-reactive protein or LPPLA2 on people who've already had a stroke? So in the Northern Manhattan study, the group of people who we had brought in the beginning, because they had a stroke, we had blood samples collected on them at the time of their stroke. And then we followed them up for several years, looking for incidents of recurrent stroke and other outcome events. And we looked at the effect of CRP and the effect of LPPLA2 over time. And we looked at these different outcome events: recurrent stroke, a combined outcome, stroke, MI, or vascular death, and death itself. And we found that after adjusting for other risk factors and demographics and both markers in the model together, that the LPPLA2 was associated with the doubling in risk of recurrent stroke, but CRP was not. When we looked at a combined outcome, the effect for LPPLA2 was a little bit less, though still significant, and CRP still not associated. But if we looked at just death alone, even after adjusting for these other factors, CRP was associated with the doubling in risk of death, but LPPLA2 was no longer associated with death alone. And so this suggests that these two markers, although both considered inflammatory markers of cardiovascular risk, behave very differently in the post-stroke setting. And it's not surprising because, as I mentioned, CRP is really an acute phase protein, meaning it's produced in reaction to injury to the body, such as a stroke. And so here you can see that in those who had the highest levels of CRP, they had more severe strokes than those in the lower quartiles of CRP. And the same was kind of true for LPPLA2, but not to the same extent and not significantly so. And so these markers, again, one CRP may measure severity of stroke, whereas LPPLA2 may be more of a measure of atherosclerotic burden. And in fact, one of the nice things about doing a population-based study in a setting where you have a hospital that provides most of the care to those people, as we do here, is that when the people in our cohort were admitted with strokes, we would visit them in the hospital and draw blood samples on them. Of course, we couldn't do it in everybody, but when we could, and there were 37 people, we found that, in fact, at the time of stroke, CRP levels go up, whereas LPPLA2 levels, like LDL itself and other lipid levels, go down. Stress leads to a decrease in the lipid levels. And so again, these markers were behaving in very different ways. So just some facts that we were able to derive about these different inflammatory markers and cardiovascular disease. Let me shift now to talk a little bit about infection. So as I showed you this slide before, and you can see that included in the things that conceivably could damage the blood vessel are infectious agents. And in fact, when I was a fellow, there was a lot of interest and enthusiasm in studying the relationship of Chlamydia pneumoniae, a common intracellular organism, and its role in causing cardiovascular disease. So Chlamydia pneumoniae can actually infect all the cell types in the vessel wall, the endothelia, the monocytes, and the smooth muscle cells. And here you can actually see a electron micrograph of a white blood cell, and there's a vesicle within it. And inside that, this is the vesicle, and inside the vesicle are these Chlamydia pneumoniae particles. And these can be identified by various means, and even cultured. You could culture live chlamydia from atherosclerotic plaque, or it's been done in rare cases. So it's clear that chlamydia are present in the vessel wall, but the question is, what is it really doing? Is it causing a problem, or was it just brought there as an innocent bystander? And there were a number of studies, including some of ours, that looked at the association of serologies against chlamydia pneumoniae and risk of stroke. And we found that there was some association, particularly for IgA antibodies against chlamydia pneumoniae. But those are retrospective or case control studies, if you will, and larger prospective studies have suggested that if there is an effect of chlamydia pneumoniae on cardiovascular disease, these were all studies in heart disease, that its effect is likely quite small, and in this meta-analysis was not actually statistically significant. So no major evidence that chlamydia pneumoniae alone is associated with risk of stroke. But I would argue that it's pretty unlikely that chlamydia pneumoniae, or any infection for that matter, is going to be the stroke bug, right? If there were such a thing, we would have discovered it already. Much more likely is that the burden of different infections one encounters throughout life contribute to this same inflammatory burden that the other risk factors like lipids and blood pressure and smoking and so forth cause, and ultimately lead to the atherosclerotic plaque. And certainly host factors, including genetics, other environmental factors contribute to that risk, leading to the cardiovascular event ultimately. And so we were able, in the Northern Manhattan study, this was one of, I think it's my first R01, we were able to go back and measure serologies directed against several different organisms and risk of cardiovascular disease. And I think I must have cut it out of this slide, so I apologize for that. But we looked at 5 different serologies, including chlamydia pneumoniae, but also H. pylori, CMV, and herpes virus 1 and 2. And we found that adding up the number of positive serologies was associated with an increased risk of stroke in the stroke-free population, even if we excluded those who had a history of MI. And those effects really did not go away even after adjusting for demographics, risk factors, and inflammatory markers like CRP and white blood cell count itself. They were very stable to those adjustments. And so this provides some evidence that that cumulative effect of infections, rather than any single infection, can contribute to risk of stroke. Jorge Luna, who is a graduate student, did some work looking at thickness of the carotid plaque and this infectious burden marker, and found that indeed the infectious burden index that we calculated was associated with plaque thickness. And Mira Katan, who was a visiting Swiss neurologist who worked with us for a couple of years, also who got a master's degree, I think she got it in biostatistics here, found that infectious burden measured the same way was also associated with measures of cognition in our cohort. Mira also went on to look at another biomarker called procalcitonin. And this is a marker that's often used in intensive care units to see whether people might be exposed to, or might have a bacterial infection, for example, when it's elevated. And she found that levels of procalcitonin in the healthy population were associated with risk of stroke as well, particularly for those in the top quartile, even after adjusting for other risk factors. So kind of a summative measure, if you will, of infectious burden exposure. And because we also did MRI scans in a subsample of our cohort, Mira was able to look at an association of procalcitonin with both silent brain infarcts, meaning discovered on imaging without any clinical history of stroke, as well as white matter hyperintensity volume, which is essentially what's being shown here, the volume of subclinical white matter disease. So supporting this idea that an infection measure could be associated with risk of subclinical disease too. So this supports this idea of a burden of infectious disease. Other inflammatory stimulators like periodontitis may be associated with that. And of course, Maurice Devarieux in our department has also explored that possibility. Now, let me just switch for a moment and talk about, instead of chronic infection and risk of stroke, the risk associated with an acute infection and risk of stroke. And in this case, what we're interested in is not so much why does one individual have a stroke versus another, but instead, why does an individual who has risk factors, say hypertension or diabetes, have a stroke on this particular day at this time instead of, 2 weeks ago or 6 months from now? In other words, this is a why now question rather than a why me question. Is this just a completely stochastic random event that you can't do anything about? Or are there periods of time at which people are at particular increased risk? And if so, there might be something we could do about it. Now, we couldn't really address this clearly in the Northern Manhattan study. So to analyze this, what I did with colleagues was to work in the cardiovascular health study, which is another large prospective cohort study, national data. And essentially, we use the case crossover design, which perhaps I don't have to say, describe in much detail to an epi audience as to a neurology audience. But in brief, consider an individual who's enrolled in the cardiovascular health study and followed over time and has a stroke on a given date. We can then look at a period of time before they had their stroke and compare it to the same calendar periods of time, 1 year and even 2 years before, and then look at the case period of time and compare it to a control period of time within the same individual to look for, what we did was to look for evidence of a hospitalization for infection in the case versus control periods. And we could vary those case and control periods in terms of their duration as well. And there were about 670 strokes in the almost 6,000 people in the cohort. And here are the infections that occurred. Altogether, about 36 infections of different types in the case periods, compared with 21 in both 90-day control periods. So the time window is twice as long. And that's the crude data. And then when we did when we calculated the odds ratios in regression analysis here, we found that there was an association of the hospitalization for infection occurred more commonly in those case periods than in the control periods. And the shorter the time window that we looked at, the stronger the magnitude of association, suggesting that the period of increased risk comes soon after the infection and then gradually goes down over time. Now, of course, this analysis, it's a within individual analysis, so you don't have to really adjust as much for risk factors, but it is still not a prospective analysis. And so to kind of confirm those results, we also did a more traditional Cox model in which we looked at time during which people were hospitalized for an infection as a time varying covariate. So people could be considered exposed while they were infected, and then they would revert back to unexposed when the infection wore off. And in those analyses, we similarly found an increased risk associated with infection, and that risk was stronger the shorter the time window, supporting that general idea. And we adjusted for other risk factors and atherosclerotic measures as well. Of course, a number of limitations to those data. I think in the interest of time, I'm going to skip over that, make the point that other studies have similarly found specific infections like respiratory infections and urinary infections associated with increased risk of stroke, and also found that vaccination is protective against stroke. And Amelia Boehm, who's well known to everybody here, has looked and used similar case crossover analyses in the HCUP data set, which is national data, in this case looking at California, and looked at influenza-like illness as a stroke trigger, and found similarly that there were associations of recent influenza-like illness and subsequent stroke. And the advantage of using this administrative data, although it's a lot less granular, and so there's a lot of potential confounders in the data, the numbers are huge, thousands and thousands of stroke patients, including people who were rather young at the time of their stroke, less than 45. And so what Amelia found in this analysis was that younger people were particular increased risk compared to older people, which may reflect the fact that there weren't other competing risk factors that might have explained their stroke instead. And Amelia found similar associations looking at sepsis as a risk factor for stroke as well, and also a significant interaction with age, again, such that the younger the individual, the higher their associated risk from a recent sepsis event. So the younger you are, the higher your risk of an infection-related stroke. And who are the youngest people we take care of? Well, they're children, of course. And so in the pediatric stroke literature, it's recognized that chickenpox or varicella-zoster virus can lead to a cerebral arteriopathy and cause stroke. And thankfully, stroke is pretty uncommon in children, so we don't see a lot of this, but it's been reported in case reports in small series that it can happen. And so I worked together with a couple of well-known pediatric stroke neurologists, Heather Fullerton at UCSF and Gabrielle de Weber, who's at what's called Sick Kids or the Children's Hospital in Toronto, on a study called VIPS, in which we explored the relationship of infection to stroke risk in children. And this was essentially a case control study. Again, stroke is very rare in kids, so we had to include centers that were really dedicated to taking care of kids with stroke. There were about 40 centers around the world that participated, including centers in China, Australia, throughout Europe, South America, and so forth. And we enrolled children who had stroke, as well as controls, who were kids who were seen in the emergency room for kind of a, expected to be random event, like a broken ankle, as well as kids who were seen in their primary care doctor's office. And the ones who were seen in the emergency room with a fracture or the stroke cases had blood samples drawn so we could look at serologies against herpes viruses. The idea being, if VZV can cause this kind of a vasculopathy, maybe other herpes viruses would as well. So we had about 350 kids with stroke and the same number of controls. And we found just by taking a history that there was an increased risk of stroke in the kids who'd had a recent infection, or really an increased risk of infection in the kids who had a stroke compared to the controls. And this held even after adjusting for some of these other demographic factors. Kids don't have a lot of other risk factors like high blood pressure and diabetes and so forth. And we were also able, in the smaller group of controls that had serologies available, and all these blood samples were sent from all over the world to our core laboratory here, but we found that there was a higher likelihood of positive serology against herpes viruses in the stroke cases. And you can see the kind of raw numbers of the positive herpes virus types here, including VZV, but other herpes viruses as well. And many of these kids, almost half, did not have any symptoms of recent infections. So these were based on serology alone without clinical history. And even after adjusting for other risk factors, there was a twofold increase in risk of stroke associated with positive serology against herpes viruses. And because we had the samples here, we were also able to look for other organisms outside the herpes virus family that might not have been included in our assays. And so we worked with Ian Lipkin and the Center for Infection and Immunity, and Raphael Tokars did these analyses. And we did mass tag PCR looking for a range of different bacterial and viral pathogens, and found that about 6% of these stroke cases had evidence of parvovirus B19, whereas none of the controls did. And in serological studies, historical controls, essentially, there was no evidence of that. And so parvovirus B19 may be yet another cause of stroke in kids. And perhaps this won't surprise people who know about sickle cell anemia, because that virus can provoke a crisis in kids with sickle cell. And it binds to many of the cell types in the bloodstream and the vessel wall. And so there's a putative mechanism by which it may lead to stroke. This, by the way, this is a child with Fifth's disease, which is caused by parvovirus B19, very common childhood infection, obviously very rarely associated with stroke. Which brings us to our most recent viral cause of stroke, which is COVID, of course. And I think I won't belabor this point here, but suffice it to say that there is a literature on the cardiovascular complications of COVID, including stroke. And I'm just going to skip over that and just say that what I think this kind of work suggests is that, you know, in the past, we thought about people having a cardiovascular event as having a vulnerable plaque. And then we said, well, maybe it's something about the systemic milieu of the patient. You know, if they have an inflammatory milieu in the body, that may contribute to their risk as well. But now we could arguably add on the vulnerable time period as well, meaning that there's a time window after which somebody has an infection when they may be at particular risk of an event. And let me just shift to talk a little bit about post-stroke trajectories. This is some neat work that I did together with Mandeep Damoon, who was one of our graduate students several years ago and a neurologist who's now at Mount Sinai. But if you think about how people go through life at a certain level of function, maybe, you know, gradually as we age, our level of, we slow down a little bit in several ways. And then let's say you have a stroke. Obviously, your function declines abruptly then, you recover over time, you then go back to the trajectory you were on before, and ultimately we age further and decline. That would be kind of the traditional view of how function evolves throughout life and the effect of a stroke. An alternative possibility, though, is that rather than just going back on that same trajectory you had before the stroke, people may have an acceleration of their decline after they've had a stroke. And, you know, stroke may exacerbate that same decline that we all have. And so Mandeep looked at this in the Northern Manhattan study, where again, we have measures of function over time in people before they have a stroke. He could then look at what happens to them starting several months after they've recovered from their stroke, and found that there's a more accelerated decline in function. In this case, we use the Barthel index. And so we have measures in people before and after stroke, and they get worse at a more rapid rate after stroke, apart from their acute event. And Mandeep looked at this as well. I think I'll just skip through this. He looked at this in the cardiovascular health study in relation to MI as well, and found that this effect of an acceleration of decline, in this case function, or this is disability, so it's going up rather than down, but disability increased more rapidly after stroke than after NMI. And others have looked at this with regard to cognition as well and found similar changes in people who've had a stroke. And we think that one of the reasons for this could be the neuroinflammatory response to having the stroke itself, that when there's injury to the brain, the immune system is activated, that leads to further neurodegeneration over time. And there's animal work done by Marion Bookwalter and Christian Doyle and others to support this idea. And so in animal models, you can see a delayed decline in cognition in a maze that mice are put in after an induced stroke, for example. It's not present immediately after the animal has had their stroke, but it comes on several weeks later. So it's a delayed effect. And in fact, that can be abrogated by using an antibody directed against lymphocytes or leukocytes in the blood. And so animals may be protected from it, and it's an open question whether we can do the same in people. In people, though, we also see that those who have an infection at the time of their stroke have a greater immune reaction against brain proteins and seem to have a greater risk of decline. And in fact, we see ambulance going by, sorry about that. in recent data out of the UK, it was found that recent infections occurring in people who've had a stroke increase their risk of post-stroke dementia. And I won't belabor that. But all of this really brings together a model of the relationship of stroke and infection over the course of the life course, if you will. And so I illustrate that here. This is from a recent review paper that we put out, whereby if you imagine somebody going through time and their function gradually declining as they age, things like chronic infections, that idea of infectious burden, may contribute to their long-term risk of having a stroke. At some point, they may have an acute infectious trigger like the flu or COVID or sepsis, and they have a stroke. They then recover, as most people do, from their stroke. And then there may be infections that are induced at the time of stroke, like pneumonia or urinary infection, that subsequently lead to decline over time. And so these infections may contribute to long-term neurodegeneration and decline. And we're currently hoping to study this in a Leduc grant called Impact, where we're looking at stroke and immune-mediated pathways and cognitive trajectories. It's primarily a laboratory-based study, but I'm serving as their kind of epidemiologist, and the idea is to try to translate some of the things they learned from animal models into human cohorts as well. And we're also following cohorts who've had a stroke, collecting blood samples to be used for further analyses, and doing neuropsychological testing at intervals after that. And I think the final thing that I'll mention is the C4R cohort, which many people here are probably involved with. But it stands for the Collaborative Cohort of Cohorts for COVID-19 Research. And it's essentially a consortium of 14 different prospective cohort studies, 12 of which are funded by NHLBI, and 2 of which, including the Northern Manhattan study, are funded by NINDS, and looking at the effect of COVID on, the effect of pre-COVID cardiovascular disease and neurological disease on risk of COVID, and then the effect of COVID itself on subsequent risk of neurological decline. And so we'll be able to address in this cohort some of these questions about the impact of having an infection like COVID, or perhaps other viral infections, on subsequent risk of neurological decline and outcomes. And so just with regard to infection and stroke, I'd say that the conclusions we could draw are that the identification of patients at increased long-term stroke risk due to infectious burden or related markers, they might become candidates for either anti-inflammatory or even anti-infectious strategies. And we've seen this already. The Heart Association has been recommending since 2003, I believe, that people should get vaccinated against the flu, not only to prevent flu, but also to prevent cardiovascular outcomes. And the same, I think, could be said of COVID. You know, not getting COVID means you won't have a COVID-related stroke either. And the idea of stroke triggers, like infection, suggests there might be that vulnerable time window during which we could treat people to prevent them from having events. And that would be similar to what we do after COVID, using antithrombotic strategies to prevent the cardiovascular complications. So I think I'm actually going to stop here. I did want to just give my acknowledgements. I'm not going to tell you about Arcadia, but I will show you this, which is just to acknowledge the Northern Manhattan study team, and especially Ralph Sacco, University of Miami, who one of my mentors, and our funding from NIH, and also collaborators on some of the other projects I talked about. And again, funding from NIH and NHLBI, and some of the drug funders as well. So I will stop there, and I hope that we do have a couple of minutes for questions. So thanks, Charlie.
About 15 minutes. And if folks want to unmute and just ask their question, that would be best. Or if you prefer, you can type it into the chat for Mitch. And thanks very much, Mitch, for a fantastic talk.
Thank you, Charlie.
This work. I mean, I can take prerogative and ask the first question. How about that?
Okay.
Can I go? I'm going all the way back to some of your earlier slides. I loved hearing about, especially about the predictability of acute infection on stroke risk and so forth. But I guess, and then I loved hearing about the C4R and the cohort of cohorts. And we have some faculty here who are involved in that, as you said, and I think maybe there's some good questions that come for that. But going all the way back to the beginning of the Northern Manhattan prospective cohort, I couldn't help noticing that there were case control studies that were part of the basis of that. And I'm wondering if you could talk a little bit about those case control studies and how those helped to launch the cohort, and maybe even talk a little bit in the weeds about some of the operational challenges or successes that occurred in terms of using those case control studies for the cohort.
Sure. So yes, so we did publish a number of studies on different risk factors. Some of them, for example, some of them that I was involved in initially were case control studies of alcohol consumption and stroke risk. 20 some odd years ago, it was still controversial what the relationship was, still controversial, frankly, but the relationship between alcohol and stroke risk. Stroke is a little bit more complicated, for example, than heart disease. There's been a long-standing thought that moderate alcohol consumption reduces your risk of atherosclerotic disease. And stroke is different because unlike heart disease and stroke, you have both ischemic stroke, often due to atherosclerosis, and also hemorrhagic stroke. And it's pretty clear, I think, that alcohol has a continuous linear dose-response association with hemorrhagic stroke. Alcohol increases the blood pressure, has effects on clotting and so forth, and so leads to hemorrhage. But the association with ischemic stroke might be similar to that for atherosclerotic heart disease at the low levels of alcohol, and then that effect may go away once you get to higher levels of alcohol. And so we looked at that by, again, interviewing our cohort of stroke cases and our stroke-free controls, and found that there was a decrement in stroke risk up to 2 drinks a day, essentially. And then there was kind of a gray area where there was no significant effect, and beyond 5 drinks a day, which was quite uncommon in our cohort in this population, at least to the extent people would report that. But those high levels were, again, associated with an increase in risk of ischemic as well as hemorrhagic stroke. And so there's this kind of J-shaped relationship. So we were able to confirm that in the case control study. And in fact, all my friends at that point, this was 25 years ago or so, kept calling me Dr. Cocktail because of this. But this is, this was always questioned because it was case control. And so several years later, we were then able to do the prospective cohort analysis, looking at the people who were enrolled in the study and followed over time, and we confirmed those results in the same group. So yeah, I would say that, our feeling, at least my feeling, was always that the case control studies were always limited by their inherent design, where you're collecting information from people who've just had a stroke, as well as people who, we say they're the same because they're drawn from the same population. Our controls all lived in the same 5 zip codes as our cases, and we're very careful about that. But of course, when you're interviewing somebody who's just had a stroke, even apart from language issues and that sort of thing, there's recall bias, and they're going to have different recall of what behaviors they engaged in. People lying in the hospital bed wondering why they had a stroke may say, I wonder if I, drank too much, or I wonder if I ate poorly, or maybe I really should tell them about those cigarettes that I've been using, that if they weren't lying in the hospital bed, they might forget to tell you about, that kind of thing. So it was I think a good example of how those limitations exist and why it's important to confirm them with prospective studies ultimately. Operationally,
That's
It
what
takes, yeah, operationally, it takes a large team of people, so we have a excellent group of research assistants. And, many of them have, moved on to great things through the years. There are people now who've gone on to, become faculty members and doctors and so forth elsewhere, spent, usually 2 or 3 years with the Northern Manhattan study, helping to enroll our participants and follow them every year. It takes a lot of hand-holding and attention to people. At different times in the past, not so much recently, we used to hold community events where we would also share the results with our population of participants so they could see what what they were contributing to. I think it's important, just like in a clinical trial, that the results are really dependent on the team that you have and those connections they make with the participants, because otherwise, if people are lost to follow-up, and you lose connection to them, then that's going to bode poorly for the quality of the results. So it's really a question of being connected to the community, and we've tried to do that. Our population has also aged over time, so we've shifted a little bit from looking at stroke to looking at cognitive outcomes. And so there have been a number of ancillary studies. Mine was on inflammation. We had others on cognition that led to the neuropsychological test data being collected. I didn't go into that in detail, the MRI study and so forth. So, it's getting people to write grants for additional testing in an existing cohort that I think has been very helpful, and I think is a good model for any growing cohort study that other people here may have.
And then I want to leave it to others to ask questions as well. But so were any of the participants from the early case control studies then used in the continue to be enrolled as part of the prospective cohort?
Well, the original cases were followed for 5 years, and then we stopped following them.
Okay.
But the controls who were enrolled during that same period of time, initially they were selected to be controls to, they were matched. In the beginning, we had matched controls. And then when we opened it up into a full prospective cohort, then we stopped doing that matching and we accelerated the enrollment of the community people. I mean, if you really want to get into the weeds on it, we had this MRI study. And so we were trying to bring people in for MRI. Our target was 1,400 people. I think we had 1,100 people agree to come back. We were struggling to meet our goals. And so we ended up bringing in what we called household members. These were people who lived in the same household as one of our original controls. So arguably, they're not completely independent because they live in the same household, but there were just a couple of hundred of those people to kind of round out our full MRI cohort. So, those of us who've been in NOMAS for 25 years know where the bodies are buried, but we try not to tell everybody. But there you go, there's a secret.
Thanks for that.
Well, I'm glad we were able to address all those issues despite the loss of the time at the beginning. That's great.
Mitch, I wanted to ask a quick question, more sort of interested in your thoughts on sort of the role of infection. I found it really fascinating. Of course, we're uncovering much more about sort of the impact of infection, sort of life risk, and sort of how it sort of alters various risk trajectories over time. But whether you or of folks who've sort of looked at sort of the ecology of infections that one may harbor over long periods of time, be it using sort of metagenomic or microbiome type studies that sort of can have an influence on certainly sort of low grade long-term inflammation. So just wanted to get your thoughts on that.
Yeah, so as I mentioned, we looked at 5 sort of pre-hypothesized infections that had been reported in individual studies to be associated with risk of cardiovascular disease and stroke. That was before, this was 20-something years ago, so it was before we had the kind of large scale, high throughput multidimensional measures that one can do now. Our recent grant cycle, we did propose to look at the microbiome more broadly. And unfortunately, that didn't get funded, at least not yet. So we're going to try to go back in so that we can look at microbiome. There's definitely growing interest. There's a fair amount already on microbiome and its association with cardiovascular disease, like heart disease,
Absolutely.
atherosclerotic disease, and specifically the metabolic breakdown products of digestion of meat by microbiome constituents and the pathological breakdown products there. And those associations with stroke and especially with cognitive disease are much less known. There's a growing literature on microbiome and Alzheimer's disease, for example. One thing I didn't talk too much about is how there's been, I would say, over the last 10 years or so, a paradigm shift in thinking about Alzheimer's disease to say that it's not just a neurodegenerative process, but has a big vascular component to it as well. So our traditional ideas of, here's vascular disease and here's neurodegeneration and never the two shall meet, that has, I think, been, largely upended. And we appreciate that neurodegenerative disease has a big vascular component. And so the association of the microbiome to Alzheimer's disease itself, vascular dementia, and kind of the combination of those is very much a hot area right now that we would like to be part of. So hopefully one of these grants will do it. Similarly, looking at other indirect measures of that, like exposomics, for example, I think would be another direction we would like to go. I don't know if that answers your question, but
it does. It's perfect. It was I just wanted to sort of get your thoughts on the various omics that are sort of tapping into the sort of ecology that is sort of ongoing with infections, inflammasomes, episomes, so on and so forth.
Yeah, and to the extent you or anyone has any ideas for what to measure with regard to that, we would be excited to do that. We have stored specimens available for all these types of analyses. Just need the money to run them.
Thank you.
That's fantastic. And are there more questions? Does anyone have any more questions? We have about a minute left. Hearing none, I wanted to thank everyone for joining us today, especially thank Dr. Elkind, our speaker, for being so understanding of all the different back and forths from room to room and back to your office on Zoom. We appreciate you being such a good sport about all this and giving us a flavor of all the great, very impressive work you've been doing. That's had quite an impact on people's health over these past decades. So we really, really appreciate hearing about that. And thanks so much, Mitch. And hope to see you all the next time. Okay.
Thank you.
Bye, everybody.
Bye.